Hello everyone and welcome to this new lecture, Fracture of the Mandible. We will give you a quick and a brief introduction, then we will discuss it later so that everyone can understand what is the fracture of the mandible and how it is dealt with. Oral and maxillofacial surgery 5th year. In this lecture, we will discuss the fracture of the mandible. A fracture is defined as a break in the continuity of the bone, which happens either as a result of violent, this here we can see a fracture is defined as a break in the continuity of the bone, which happens either as a result of violence or because the bone is unhealthy and unable to withstand normal stresses. Either the bone is unhealthy or either as a result of violence. Fracture of the mandible are common due to the prominence of the mandible. Here is the mandible. The impact forces that are required to produce mandibular fracture are higher than those of the maxilla. The teeth, the fracture of the mandible are common, but the force, because the mandible is prominent and the force is less, is more than the maxilla to fracture the mandible. The teeth are important in developing determining where fractures occur. The long canine tooth and the primary erupted or unerupted wisdom tooth. Both represent lines of relative weaknesses. The partially erupted or unerupted wisdom teeth is a weak point, and the canine tooth is another weak point of mandibular fracture. Classification of mandibular fracture according to the type of a fracture. Mandibular fractures can be classified into simple, closed, a type of single closed fracture that doesn't have continuation with the external environment. This is the first type of classification of mandibular fracture, is the simple according to type. We have the simple fracture type of single fracture that does not have continuation with the external environment, but comminuted fracture, compound fracture, or open fracture. Sometimes it's called open, sometimes it's called compound. And this fracture is unlike the simple closed fracture, have an extension into the external environment, though through the skin or mucosa or periodontal membrane. The third type is called the comminuted. So the first type is simple, single, closed. The second type is comminuted, open. The second type is compound open fracture. And the third part is comminuted, when the bone is fragmented into multiple pieces, multiple broken and other usually the comminuted, when the bone is fragmented into multiple pieces, this usually requires considerably more energy than does a simple fracture. This one is called the comminuted. The comminuted requires more energy than the compound and more energy than the simple fracture. Other type of a fracture is called the green stick fracture, when only one cortex of the bone, this is one cortex of the bone, is broken. The other cortex, this is the other cortex, this one is broken and this one is not broken. The green stick, when only one cortex of the bone is broken, with the other cortex being bent. It is found exclusively in children. So this one is broken and this one is bent. One cortex is broken and one cortex is. We have the other type, is called the pathologic type of fracture, caused by pre-existing pathological condition of bone, usually. Such fracture, such as osteomyelitis, so the pathologic fracture caused by pre-existing pathological condition of the bone, such as osteomyelitis. And the other type is called neoplasm, or generalized skeletal disease that leads to fracture from minimal trauma. This is the pathologic, and this is the gradistic, comminuted, compound, and the simple fracture. There is also after we have finished the pathological, we now talk about the complex or complicated. The complicated, unlike the compound and unlike the complex, the complex is unlike, or the complicated or complex is unlike the compound and unlike the green stick, not like the simple closed, and not like the comminuted. The comminuted when the bone is fractured into multiple pieces. Let's talk about the complex and how it is different from the compound and the comminuted and the simple and green stick and pathological fractures. This one is compound or complex or complicated. Fractures associated with the damage to the important vital structures, complicating the treatment as well as prognosis, including the severely atrophied mandible. The severely atrophied mandible, and there is now also a single, as you can see in the bottom of the screen, we have a single. The single is not like the simple. The simple is open, but the simple only one fracture line in the same bone, only one fracture line in the same bone. Now this page is done, but we still have 16 pages left. Now we will examine and see the multiple two or more lines, multiple fracture that are two or more lines of the fracture on the same bone that do not communicate. Fracture of the mandible can also be classified according to the anatomic site, including dentoalveolar and including condylar, coronoid, ramus, angle, body of the mandible, this one, and it includes the molars and the premolars. Symphysis, parasymphysis. Mandibular fractures classified according to their tendency to displace as a result of the pull of the attached muscles into favorable and unfavorable. Favorable when the muscles tend to pull the fragments together, minimizing displacement. When unfavorable is described when they are significantly displaced by the muscle. When they are significantly displaced by the muscle. These fractures are compromised or considered as vertically or horizontally favorable or unfavorable fractures, depending on the direction of the displacement, although this principle can be applied to any fracture of the mandible where there are muscles attached. In this, it is most commonly used with angle fracture. Angle fracture, as we discussed earlier, angular fracture includes the pterygoid, medial pterygoid muscle, and also the masseter muscle. Therefore, it is mostly involved with unfavorable fracture. Direct and indirect fracture. When the fracture is applied to the mandible, when the force is applied to the mandible, the point of application of the force is compressed, causing direct fracture, and the resultant vector travels along the bone and applies tensile force on the point intersected by this vector, causing indirect fractures. Whenever a direct fracture is seen at the site of primary impact, one must examine the corresponding indirect fracture sites and rule out the indirect fracture. This is the end of the paragraph. Common combination of direct and indirect fractures are: we have the symphysis, which is direct fracture in combination with the bilateral subcondylar examples for such direct and indirect fractures include symphysial direct, here the symphysial direct, fracture combined with the bilateral subcondylar fracture it is indirect subcondylar fracture bilaterally, also called parade ground fracture or Gordman's fracture. There is another type of a direct and indirect fracture called the parasymphysial direct fracture combined with the contralateral subcondylar or angle indirect fracture. Subcondylar or angle indirect, and bisymphysial direct fracture or parasymphysial direct fracture with a contralateral fracture indirectly. There is another type called body. It is the body subcondylar, body direct fracture combined with contralateral angle or subcondylar fracture, indirect fracture. Also, the subcondylar, or the three, are from symphysia, parasymphysia, and body combined. The body is combined with contralateral angle or subcondylar fracture. Even sometimes the angle and sometimes the subcondylar indirect fracture. Again, let's repeat so that we can understand and keep it in mind. We have number one, the symphysial direct fracture combined with the bilateral subcondylar indirect fracture, also called parade ground fracture or Gordman fracture. This one is the first one. It is at the bottom of the screen, you can read it. Then the second type is the parasymphysial direct fracture combined with contralateral subcondylar or angle fracture. Subcondylar or angle. This is the second with the parasymphysial. The third, body fracture, not parasymphysial this time, direct fracture combined with contralateral angle or subcondylar indirect fracture. Also subcondylar. Every three has had a subcondylar fracture. The last one is with the angle and subcondylar, coming from the body. The body, contralateral angle or subcondylar. And the second one was three types of direct and indirect fractures in the same time. The first one is symphysis, with bilateral subcondylar. The second one with parasympathesis with subcondylar or angle of the mandible. The third one is the body of the mandible, direct and with an indirect subcondylar or angle of the mandible. These are the three, direct and indirect combination of fracture of the mandible. These are the clinical features, and we will study it briefly now, and then we will give you what is the meaning of all of these paragraphs. Now we will read to you these paragraphs and explain it to you. Clinical features. The main clinical features of mandibular fracture include pain, especially on talking and swallowing, leading to drooling of saliva, swelling due to edema and hematoma causing facial asymmetry. Here is where we are reading. The teeth near the fracture site may become loosened, displaced, or avulsed with the laceration of the gingiva. Bleeding from the fracture site There are many clinical features of the fractured mandible. The main clinical features of the mandible fracture include pain, especially on talking and swallowing, leading to drooling of saliva, swelling due to edema and hematoma, causing facial asymmetry. The teeth near the fracture site may become loosened, displaced, or avulsed with laceration of the gingiva. Bleeding from the fracture site can also occur. Trismus and difficulty in moving the jaw. Bone tenderness over fracture site. Mobility of a fracture segment. Step deformity palpable at the site due to palpable at the site due to the displacement of the fracture segment. Again, step deformity palpable at the site due to the displacement of the fractured segment. Malocclusion, of course, we have malocclusion. Sublingual hematoma, which is regarded as pathognomonic, of course, it is regarded as pathognomonic. step deformity, palpable, malocclusion, sublingual hematoma, which is regarded as pathognomonic sign of fracture. In some cases of bilateral subcondylar fracture with condylar displacement and shortening of the ramus, leading to the premature connect of the posterior teeth and anterior open bite. So we have in this point anterior open bite in some cases of bilateral subcondylar fracture with condylar displacement and shortening of the ramus that leads to premature contact of the posterior teeth, allowing the tongue. Bilateral premature fracture may be readily displaced posteriorly under the the step deformity palpable at the site due to the displacement of the fracture segment, numbness of the lower lip due to injury to the inferior alveolar nerve, malocclusion, sublingual hematoma, which is regarded as a pathognomic sign of fracture. In some cases of bilateral subcondylar fractures with condylar displacement and shortening of the ramus, leading to premature contact of posterior teeth and anterior open bites. Bilateral parasymphysial fracture may be readily displaced posteriorly. This one is a bilateral parasymphysial fracture, may be readily displaced posteriorly under the influence of the genioglossus and geniohyoid muscles constitutes threats, allowing the tongue to fall back and obscure the oropharynx, which constitutes a threat to the airway, especially in the patients with depressed levels of consciousness. Next point, here I will point at it, in some cases of condylar fractures, bleeding from the ear may result from laceration of the anterior wall of the external auditory meatus. It is important to distinguish bleeding originating in the external auditory canal from the more serious middle ear hemorrhage, which which is significant, which signifies a fracture of the petrous temporal bone and may be accompanied by cerebrospinal otorrhea. Next, we will talk about imaging, or the image. Here I will point at it. Image. The clinical diagnosis of the fracture is essential, but radiographs confirm the diagnosis of the fracture and are mandatory. The primary or the principle is to obtain at level the principle is to obtain at the level at least two views, each taken at right angle to the other, in order to assess the degree of displacement and angulation of the fractures. The radiographs, as we discussed earlier, and the imaging, of course, the clinical diagnosis of the fracture is important, but also radiograph is needed. What are the types of radiographs? First is called the Panoramic Radiograph, OPG, that represents the best single overall view of the mandible, including the condyles. The combination of the posterior anterior view of the mandible and the OPG usually provide a complete view of the mandible. If OPG is not available, PA mandible with left and right oblique lateral view can be taken. This one is only if OPG is not available. The Townes projection is the next type that we will talk about now. Anterior-posterior, it is the same anterior-posterior Townes projection, and there is the reverse Townes projection in both these projection, anterior-posterior, reverse anterior-posterior Townes projection. The projection, the central ray angle at 30 degrees to the horizontal baseline, which shows the image of the condyle head and subcondylar region, clear of the dense bony structures of the base of the skull. Occlusal view are valuable for demonstrating midline fracture of the mandible with minimal displacement. CT scan is not normally undertaken for isolated mandibular fractures unless there are complicating fractures such as significant comminution. It is also useful in the assessment of the displaced and comminuated fractures of the condylar region, where it will demonstrate considerable detail that would otherwise not be clear on standard radiographs. Treatment. The aim of treatment is primarily to restore function, namely to restore both the occlusion and pain-free normal movements of both TMJs, both the occlusion and pain-free normal movements of both TMJs. Fractures affecting treatment of mandible fracture, or factors affecting treatment of mandibular fracture. The fracture pattern will affect the treatment of mandibular fracture. The skill of the operator, the responsiveness, the resources available, the general medical condition of the patient. The degree of facial contamination and infection, associated soft tissue injury or loss. This one is also important, associated soft tissue injury or loss. The principles of treatment of the fractures are reduction. It is the restoration of the functional alignment of the fracture bone fragments. The first one is the reduction, which is restoration of the functional alignments of the fracture bone fragments. Second is fixation. Then we have immobilization, and last, rehabilitation. Now we have said many things about the skill of the operator, the fracture pattern, the degree of, as we can see here, I am pointing here. Here, the fracture pattern, the skill of the operator, and many things that to be considered. The prediction here, the principles of treatment of fractures are, there are 4 principles of treatment of the fracture. Reduction, it is the restoration of functional alignment of the fractured bone fragments. This is the first one here, the reduction, which is the restoration of the functional alignment of the fractured bone fragments. Second is the fixation. Then we have the immobilization. And last but not least, we have the rehabilitation. Treatment of mandibular fractures can be closed or open treatment. Of course, treatment is important of mandibular fracture, and they can be closed treatment and they can be open treatment. Starting with a closed treatment, it consists of closed reduction, here, with indirect fixation. This one is closed reduction with indirect fixation, and immobilization with inner maxillary fixation. With immobilization with intermaxillary fixation, also called mandibulomaxillary fixation, MMF here, MMF. It is the traditional conservative treatment of mandibular fragments. Closed reduction is achieved without surgical exposure of the fracture site. Without surgical exposure of the fracture site, by manipulation of elastic traction and indirect fixation, utilizes the standing teeth to place the teeth in normal occlusion, and utilize the standing teeth and immobilize them in that position, thus indirectly reduce the bone fragments. This method can be used as a definitive treatment of the mandibular fracture or as a temporary fragment stabilization. Here, temporary fragment stabilization. In emergency cases, before definitive open treatment. This one is before definitive open treatments. The main indication of closed treatment are non-displaced, favorable fractures. When we see a non-displaced favorable fracture, we can use the closed fracture, closed treatment. Limited resources and facilities for open treatment. Medically compromised patients where conservative line of treatment is required. Grossly infected fractures. Pediatric fractures with mixed dentition phase. Pediatric fractures with mixed dentition phase and edentulous fractures. Here, edentulous fractures. Advantages of closed treatment. What are the advantages of closed treatment? Non-invasive, simple, easy to master, can be performed under local anesthesia, less expensive. Three advantages. Non-invasive, can be performed under local anesthesia, and less expensive. What are the disadvantages? Here we can see the disadvantages of closed fracture. The closed treatment does not ensure anatomic reduction of the fracture. Closed treatment does not, again, disadvantages, does not ensure enclosed anatomic reduction of fracture. In certain cases, closed treatment may be difficult, especially in cases of malocclusion, missing, diseased or damaged teeth. In certain cases, missing, diseased, etc. teeth. The immobilization may not be adequate, which delay the healing. The treatment induces morbidity to the patient due to the intermaxillary fixation affecting feeding and speech. Last point here, we can see it. This one is the last point. Close treatment is contraindicated in some conditions as epilepsy, chronic respiratory disease, incompetent patient, or chronic alcohol or drugs abuse. Methods of immobilization. We have all these methods for intermaxillary fixation, mandibular maxillary fixation, starting with methods, or let's give a brief introduction. After proper reduction and achievement of good occlusal relationship, the upper and lower jaws are immobilized by fixing them together in occlusal relationship by inner maxillary fixation. This can be achieved by bonded orthodontic brackets. This is the first one. By bonding a number of modified orthodontic brackets, bonding a number of orthodontic modified brackets onto the teeth and applying light wires on inner maxillary elastic bands. This one is the first one. By bonding a number of modified orthodontic brackets onto the teeth and applying light wires or inner maxillary elastic bands. The second method, here we can see it, interdental wiring. This method is only applicable when the patient has a complete or almost complete number of suitably shaped teeth. 0.5 millimeter soft stainless wires usually used. Many different techniques for wire fixation exists, such as direct interdental wiring and eyelet or ivory loops. After applying the fixation wires, the wires are applied to immobilize the mandible. There is another method for immobilization. It's called arch wire. They are both bone devices used in inner maxillary fixation of dentate patients. Arch bars are both bone devices used in inner maxillary dentate patients. They are the most versatile form of inner maxillary fixation. Arch bars are indicated where the patient has an insignificant numbers of suitably shaped teeth, or when a direct linkage across the fracture is required. They are indicated where the patient indicated where when indicated where the patient has an insufficient number of suitably shaped teeth, or when a direct commercially manufactured available in aluminium, stainless steel, and nowadays also titanium, as well as various alloys. Many patients or recently hybrid arch bar systems that used bone. Many patients or designs of arch bars are present, such as Eric, and many patterns or recently hybrid arch bar systems that use bone support have been developed. So we have until now 3 bonded orthodontic brackets for inner maxillary fixation, immobilization. Second one is called interdental wiring, and then we have arch bars. Now we talk about inner maxillary screws. Here is the inner maxillary screws. These screws are self-drilling and self-tapping. The screw's head is elongated and contains holes or wires placement. They are inserted through small incisions to the labial vestibule, avoiding injury to the apices of the nearby teeth. It's just to avoid injuries. They are in labial vestibules, avoiding injury to the apices of the nearby teeth. It is regarded as a rapid method to achieve inner maxillary fixation. The last technique after we have finished the inner maxillary fixation: screws, inner maxillary fixation screws, arch bars, interdental wiring, bonded orthodontic brackets. Now we talk about cap splints. Are fabricated by making an impression of the fractured jaw and preparation of the cast, on which a cap splint made of acrylic or metal can be fabricated and used for fixation of the fracture. Again, cap splints, they are fabricated by making an impression of the fabricated jaws and preparation of the cast, on which a cap splint made of acrylic or metal can be fabricated and used for fixation of the fracture. Now we will talk about some other types of intermaxillary fixation. One type is called the denture or gunning type splint. The denture or gunning type splint. And this one is important in edentulous jaws fractures. Complete denture can be used, as we can see, as a splint. And if the patient is not a denture wearer, gunning type splint can be fabricated. They are fixed to the jaws by circummandibular and maxillary pre-alveolar wires or screws. In intermaxillary fixation, and intermaxillary fixation is achieved by connecting the two splints with wire loops or elastic bands. How about external pin fixation? This method is seldom used nowadays. External pin fixation. It is indicated in special conditions such as infected fractures, fractures caused by gunshot injuries, or pathological fractures. Ideally, at least two self-tapping screwed spins are placed either side of the fracture or defect. The fracture is then reduced and the pins linked by an external bar fragments. Framework. Next type we have period of immobilization. This one is not a type. This paragraph is not a type. Indeed, it is an explanation for the intermaxillary fixation. And to give you an idea about that, intermaxillary fixation. With early uncomplicated treatment in healthy young adults, union can, on average, be achieved after 3 weeks. 3 weeks, on average, at which time the fixation can be released. As an empirical guide, a further 1 to 2 weeks should be added for each and any of the following circumstances. So not only 3 weeks, but an additional 1 to 2 weeks should be added in all these 4 circumstances where a tooth is retained in the fracture line. Tooth is retained in the fracture line. Patient aged 40 years and over, older patients, patients who are smokers, mobile or comminuted fractures. Rules such as these are designed for guidance only, and it must be emphasized that the intermaxillary fixation should be released and the fracture tested clinically before the fixation is finally removed. So the fracture has to be examined clinically before the fixation is finally removed. Open treatment. This one is not intramaxillary fixation. This one is an open treatment. It consists of open reduction and internal fixation. Here we can read it. It consists of open reduction and internal fixation, ORIF, or direct skeletal fixation. So sometimes it is open reduction internal fixation, sometimes it's skeletal fixation. In open reduction, the fracture site is surgically exposed and the fracture is reduced under direct vision, and the fractured fragments are immobilized by different internal direct fixation methods. Open reduction internal fixation is now considered the main method of treatment of mandibular fractures. The main indications for open treatments. What are the main indications for open treatments? We will mention only two in this page 7, and later we'll mention more indications in the page 8. First indication for open reduction internal fixation is displaced unfavorable fracture. Second indication is multiple fractures due to facial of the facial bones, multiple fracture of the facial bones. There are, after we have discussed before the intramaxillary fixation, and now we have to discuss the internal fixation, open reduction internal fixation. More indication of internal open reduction internal fixation are fractures of an edentulous mandible with severe displacement, delay of treatment and interposition of soft tissue between non-contacting displacement fracture fragments. Here, I will read it again. Number 4, delay of treatment and interposition of soft tissue between non-contacting displaced fracture fragments. Number 5, we have special systemic conditions contraindicating internal maxillary fixation. Depending on the planned method of internal fixation and the site of the fracture, and method of internal fixation, of reduction internal fixation. We have 3 different surgical approaches to the mandibular body with slight modifications. Are possible. We have intraoral, extraoral, or combined access. Methods of internal fixation osteosynthesis. Number 1, intraosseous transosseous wiring. Number 2, mini plates. Number 3, 3-dimensional. Number 4, non-compromised rigid plates. Starting with intraosseous or transosseous wiring. In the direct skeletal fixation of 2 or more bone fragments with the aid of wire ligature pulled through previously drilled holes, it is considered a non-rigid fixation method. Transosseous wearing. Number 2, we have mini plates. Miniaturized plates. These are the most common form of internal fixation used in the management of mandible fracture. They provide semi-rigid or load-sharing fixation. The mini plate or principle involves placing the mini plates in anatomically correct position. The plate can be anchored using only the outer cortical bone with so-called monocortical screws, which are 2 mm in diameter. 3-dimensional titanium mini plates. Here we have them. The 3-dimensional titanium mini plates are based on the principle of quadrangle as geometrically stable configuration for support. The plates are adapted to the bone and are secured with the monocortical self-cutting screws. Next, we have non-compression rigid plates. Reconstruction plates. These plates provide rigid or load-bearing fixation. They are mostly used in the management of infected, severely comminuted fracture in delayed union or non-union has occurred. They require bicortical screws and are fixed in place at or near the lower border of the mandible in order to avoid damage to the inferior alveolar nerve and dental roots, called non-compression rigid plates. Non-compression rigid plates. There are more techniques and screws that we can shall use in the open reduction fixation cases. Some of those here we can see compression plates. We have studied before the non-compression plates, but now the compression of these plates provide rigid fixation. The principle of compression plates is by transforming the downward force of screws intersection into a compressive force. And this type of plates does not offer much advantage to the patient in their treatment. Like screws here, in oblique fractures, compression-like screws can be applied without plates. They are placed perpendicularly across the fracture line in order to avoid displacement or to avoid displacing the fragments. Parasymphysial. This technique appears to be ideal for parasymphysial. Here, parasymphysial. Unsymphysial fractures. But it becomes technically more difficult in body or angle of mandible because the risk of damage to the inferior alveolar nerve. Now we study the bioabsorbable plates and screws. These are made from material that undergo degeneration, so they do not have to be removed after fracture healing. They are mainly indicated to pediatric fractures. Teeth in the line of fracture. Now we have finished the screws, the X screws, and all used in interfixation in external reduction, internal fixation. Now we will study teeth in the line of fracture. Teeth in the fracture line may cause infection of the fractured site either from the oral cavity via the disturbed periodontium or directly from an infected pulp or chronic apical infection. Infection of the fracture site will result in protracted healing or even non-healing. Absolute indications for removal of tooth. Here we can see from the fracture line. Number 1, longitudinal fracture involves the root. Number 2, dislocation of the sub or subluxation, dislocation or subluxation of the tooth from the socket. Presence of periapical infection, advanced periodontal disease, already infected fracture line, acute pericornitis, and where a displaced tooth prevents reduction of the fracture. Now to the relative indication for removal of tooth from the fracture line, we have number 1, functionless tooth that would probably eventually be removed, and number 2, advanced caries, number 3, doubtful teeth that could be added to existing denture. Now we have many important, otherwise, like in this paragraph it says like, otherwise that the structure under undamaged and potentially functional should be retained and antibiotic administered. Teeth in line of fracture should be followed up for 1 year and should be endodontically treated if there is a demonstration of loss of vitality. If a fracture becomes infected, immediate extraction should be performed only if the fracture is becoming infected. So again, otherwise the teeth that are structurally undamaged, functional, should be retained. Let's talk about the complications of mandibular fracture. Intraoral and early post-operative complications include misplaced fixation, infection of the fracture site. Starting with misplaced fixation. Damage caused by the misplaced fixation device, the transosseous wires or plates, the risk of damage to the structure within the body of the mandible, like the inferior alveolar canal and root apices, is less when using monocortical screws. This one is having an issue with screws other than monocortical screws, saying that damage caused by the misplaced fixation device like transosseous wiring or plates, they are not like the monocortical screws. The risk of damage structure within the body, like the inferior alveolar canal and root apices, is less when using monocortical screws. Second, we have the infection of the fracture sites. The main contributing factor or the main contributing factors, we have compound inadequate loose and immunocompromised. Compound fracture with gross contamination. This one is a contributing factor to the infection of the fracture site, is a compound fracture with gross contamination. The second is inadequate stabilization of the fracture, loose of fixation device, and immunocompromised patient, example diabetes and alcoholism. Most infections are usually mild, with intraoral swelling and discomfort. However, these can progress to cellulitis, abscess formation and fistula, osteomyelitis. Here we have osteomyelitis, and rarely necrotizing fistulitis. The infection should be prevented by good antibiotic prophylaxis, maintaining of wound hygiene, adequate immobilization, effective management of the tooth involved in the fracture, in the fracture line, and ensuring that the fixation devices are not loose the infection will invariably interfere with the healing of the fracture. This infection will invariably interfere. But, as we said before, most infections are usually mild, with intraoral swelling and discomfort. However, these can progress to cellulitis, etc. The principles of management of these include: number one, control of the infection, incision and drainage, and antibiotics. Number two, we have removal of any focus of infection, teeth, sequestra, or plates and screws. Optimizing the healing environment is also important to optimize the healing environment. Patient health and oral health. Last is immobilization of the fracture. We have now nerve damage and other things that we will discuss later. Let's talk about the nerve damage. Nerve damage, anesthesia or paresthesia of the lower lip as a result of injury to the inferior dental nerve is the most common complication. Inferior dental nerve or inferior alveolar nerve is the most complication of fracture of the body of the mandible. Damage to the inferior alveolar nerve can also result from treatment, which is most commonly associated with the open treatment. Facial nerve damage may complicate some fracture, facial nerve may complicate some fractures on the ramus and condyle, either as a result of penetrating injury, severing branches of the nerve, or blunt trauma. Again, I will repeat this. Facial nerve damage may complicate some fractures of the ramus and the condyle, either as a result of penetrating injury, severing branches of the nerve, or blunt trauma. Late complications. We have malunion and delayed union. Starting with and there is non-union in the other page. But starting with late complication of malunion, the healing of the fracture is an abnormal or non-anatomical position. The healing of the fracture is in an abnormal or a non-anatomical position. It can occur as a result of inadequate reduction, inadequate mobilization, or if no treatment is done. It may result in occlusion discrepancies and poor aesthetic. And if malalignment is noticed early in the post-operative phase, it may be corrected by returning the patient to the operative room for repeated reduction. Minor malunions do not usually cause major clinical problems because the dentition often readjusts to a new bite. Alternatively, judicious selective grinding can balance the new occlusion satisfactorily. However, significant malunions of the mandible can produce gross occlusal derangement and facial deformity, which can be resolved by operative reconstruction, usually in the form of refracture or planned osteotomy. Refracture or planned osteotomy or osteotomy with rigid fixation bone graft may be required in some cases. Delayed union. It occurs when the union of the fracture segment is delayed beyond the expected time for that particular fracture. It results from disturbance of the healing procedure, the healing process, by local factors such as infection, general factors such as osteoporosis, nutritional deficiency, the delay in union in the management. The delay in union is managed by prolonging the period of immobilization. We have to now study the non-union. Non-union is a failure of the fracture to unite on its own. Non-union can be caused by local or general factors. Sometimes local and sometimes caused by general factors. Infection of the fracture site causing a non-union. Inadequate mobilization and excessive mobility of the fractured fragments. Unsatisfactory apposition of bone ends with interposition of soft tissue. Thin, ultra-thin edentulous mandible in an elderly debilitated patient. Less bone and soft tissue as a result of severe trauma, example missile injury. Inadequate blood supply to the fracture site, example after radiography. The presence of bone pathology, example malignant neoplasm. And a general disease, example osteoporosis, severe nutritional deficiency, diseases of the calcium metabolism. In non-union, the fragments are united by fibrous tissue rather than the bone, and pseudoarthritis false joint results. The bone ends becoming rounded off and sclerosed ebonation. Treatment is surgical exploration of the fracture, surgical exploration of the fracture site, and any obvious impediment to healing, such as sequestrum or devitalized tooth, that should be removed. The bone ends are then freshened, and the jaws are immobilized using rigid fixation. Bone graft may be needed. Bone graft may be needed. Complications associated with internal fixation. These may include posture of the plates, especially when placed near oral mucosa. Plates may also become infected. Transosseous wears may cause pain or discomfort. So they could be exposed, especially when they are near the mucosa. They could cause pain. Sequestration of bone. Comminuted fractures of the mandible may be complicated by the formation of bone sequestrae. A sequestrum may be a cause of delayed union, or act, as we can see here, a cause of delayed union, or act as a potential source of infection. In some cases, a sequestrum may extrude spontaneously into the mouth with quiet, minimal symptoms, but otherwise a localized abscess forms and surgical removal of dead bone becomes a necessity. Again, let's talk about the sequestrum. Combinated fracture of the mandible may be complicated by the formation of bone sequestrae. A sequestrum may be a cause of delayed union or act as a potential source of infection. In some cases, a sequestrum may extrude spontaneously into the mouth with quiet, minimal symptoms, but otherwise in localized abscesses, forms, and surgical, but otherwise a localized abscess is formed and surgical removal of the dead bone becomes necessary. Mandibular fracture. Mandibular fractures that require special consideration include pediatric fractures. Fractures of the mandible are uncommon in children, and some modifications to the principles of treatment are necessary in the fracture occurs in the child. When the fracture occurs in child, the main characteristic of mandibular fracture in child are 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Bone in young children is resilient, and gainsting fracture is more likely to occur, and there is a great risk of damage to the developing teeth. Mandible fracture in young children heal very rapidly, and some fractures are stable within a week and firmly united within 3 weeks. Treatment is generally of conservative nature. Mandible fractures may disturb the growth of the mandible if unerupted. Permanent teeth or teeth germs are lost. Fractures of the condyle require special consideration when fixation is needed in very young with unerupted or very few deciduous teeth. A splint for the lower jaw alone may be used. This is constructed as a simple acrylic and retained by 2 light circummandibular wires. When significant firm, erupted, deciduous, and permanent teeth are present, cyclic wires or arch wires can be used. When there is significant displacement of fragments or reduction in internal fixation, may be necessary. In this situation, any plate or wire fixation must be strictly confined to the lower border to avoid damage to the developing teeth. Again, strictly confined to lower border to avoid damage to the developing teeth, wire fixation. Slight imperfection to the in reduction can be accepted. Here we can see it. Slight interaction reduction can be accepted when a fracture is treated. Because continuing growth and eruption of teeth will compensate in most cases for the imperfect alignment of the fragments. Last, prolonged follow-up is required in order to be sure that there are no long-term effects on both mandibular growth and the normal development of the permanent dentition. Prolonged follow-up. We have other special case, as we mentioned before, after we have said that there is a mandibular fracture that requires special attention and special considerations after the perineal patient. We have a fracture to the condyle, fracture involving the mandibular condyle, the only bone fractures that involve the synovial joint. Many classification systems have been proposed for fractures of condyle region. Generally, they can be classified into fractures of the head, of the condyle, intercapsular or neck of the condyle. Now let's talk about the treatment of the condylar fracture. Here it is. All intracapsular fractures and all fractures in growing children should be treated conservatively. Immediate or early immobilization should be encouraged. However, if the occlusion is disturbed, intermaxillary fixation is applied and maintained until a stable union can be expected to present. The period of immobilization should not exceed 10 to 21 days. Again, treatment of condylar fractures, all intracapsular fractures and all fractures in growing children should be treated conservatively. Immediate or early immobilization should be encouraged. If occlusal is disturbed, intermaxillary fixation. There is a problem here. I don't know if intermaxillary fixation is different from immobilization treatment. So we have intermaxillary fixation and we have intermaxillary fixation and we have mobilization. Early mobilization should be correct. All intercapsular fractures and all fractures in growing children should be treated conservatively. Immediate or early mobilization should be encouraged. However, if the I think I understand now. So sometimes it's early mobilization and sometimes intermaxillary fixation is required for the patient to be treated. But of course, not exceed 10 to 21 days. Open reduction internal fixation of condylar fractures. Absolute indication of open reduction internal fixation of condylar fracture is number 1, displacement of condylar into middle, cranial, fossa, impossibility of restoring occlusion with closed treatment, lateral extracapsular displacement, invasion by foreign body like a missile, relative indications. Number 1, bilateral fracture with associated mild fracture, mid-face fracture, particularly where one condyle fracture is dislocated or angulated. Bilateral fracture with severe open bite deformity. Unilateral fracture with dislocation, overlap, or significant angulation of the condyle head. When intramaxillary fixation is contraindicated for medical reasons. Now let's go to the surgical approach of upper reduction internal fixation. Surgical approach. The main approaches to the TMJ are the pre-auricular, submandibular, retromandibular, or transparotid approaches. The intraoral approach has the advantage of avoiding facial scarring and risk of injury to the facial nerve, but the major disadvantage is limited access. Third, here we can read, minimally invasive endoscopic repair of condylar. Fracture offers less morbidity and operative time as well as quick patient recovery. Fixation methods of upper reduction internal fixation. Among the fixation methods that have been used are transosseous wire, Kirschner wire, mini plates, laxacrose, bioresorbable plates and pins, and more recently ultrasound activated resorbable plates and pins. Let's talk about the complication of upper reduction internal fixation. First is the malocclusion, then limitation of range of movement. Later we have the displacement of the disc, reducible or irreducible. Then we have a chronic pain associated with dysfunctional movement, or with osteoarthritis. Ankyloses of the TMJ, features that involve the joint space, particularly in young patients, seem most prone to result in this complication. Ankylosis can be fibrous or bony. Predisposing factors to ankylosis include 1, 2, 3, 1, age. The major incidence is below the age of 10. Type of injury, intercapsular trauma with crushing of the condyle. Number 3 of Ankylosis includes damage to the disc. This rupture of the disc is likely to occur in two particular types of fracture: a severe intracapsular compression injury or a fracture dislocation. We have now to study the disturbance of growth in children. That's another complication of open-reduction Pin Fixation. Disturbance of growth in children when the fracture involves the condyle, involves the condylar cartilage, on the articular surface. Subsequent disturbance of growth may occur. The effect of damage is failure of development of the condyle, process, and smaller mandibular on the affected site. Fracture of the edentulous mandible. The physical characteristics of the mandible are altered considerably following the loss of teeth. The alveolar process undergoes resorption and the mandible becomes atrophic and thin. The resistance of the bone to trauma is further reduced by change in the structure of the bone associated with the process of aging. The bone supply of edentulous mandible is more periosteal due to the diminished endosteal blood supply of the mandible. The healing potential of the bone is reduced, and the healing of the fracture is a slow process, and the complications such as non-union are more likely to occur. Smaller cross-sectional area of bone at the fracture site and the absence of the stabling influence of the teeth. Fractures are much less frequently compound into the mouth than when teeth are present. As a result, if treatment is by closed reduction, the risk of subsequent infection is much reduced with edentulous patients. The treatment. Undisplaced fractures, here we can see, requires no active treatment. The edentulous mandible fracture can be treated by closed reduction using the gunning type splints. Again, the dangerous mandibular fracture can be treated by close reduction using the gunning type splints, or if the patient is a denture, the dentures can be modified to allow intramaxillary fixation, which can be used as a splint. When overreduction internal fixation is required, reduction should be made with minimum exposure of the fracture site to minimize interference with the periosteal blood supply. Autogenous bone grafting may be needed in very thin mandible. It must be remembered that accurate anatomical reduction is not required, as any it must be remembered that accurate anatomical reduction is not required, as any inaccuracy is easily compensated by adjusting the dentures, and that in very thin mandible, stable fibrous union may be an acceptable result in the very old and infirm patients. Comminuted mandibular fractures result from high energy injuries such as missile injuries. These injuries are associated with a soft tissue damage, and many of these fractures are open, compound, and contaminated. The bone fragments are often difficult to manipulate and secure, while maintaining their soft tissue attachment, and are therefore at risk of becoming loose, devitalized later on. The traditional method of treatment of these fragments or fractures, the traditional method of treating these fractures used closed techniques, thereby avoiding periosteal stippling and further devitalizing the bone. Recently, open reduction internal fixation has been advocated to provide a load-bearing fixation and stability across the fracture and severe injuries after airway and hemorrhage control, temporary INF, or external fixation can be used until definitive open reduction internal fixation is made. Thank you for hearing and joining us in this lecture. It wasn't the hardest lecture in the world. It contained